Well, good evening, ladies at home. I'm so glad that you're joining us for another webinar, Menopause Chat. And tonight's topic is something that is near and dear to my heart because it is a rare patient who doesn't come in the perimenopause or menopause transition who doesn't have some questions or issues with weight. So I am thrilled to be joined tonight by WellSpan's menopause weight loss expert, Jennifer Hutsler. Jennifer is a nurse practitioner who specializes in medical weight management. Thank you for being with us tonight, Jennifer.
You're welcome. It's nice to be here. Thank you.
So I thought I would just touch briefly on what the issue is with weight and menopause, because I don't think it's that unusual that women at various times in their life struggle with weight loss, and you know, a lot of us have been on various diets throughout our life, but it seems like something really kicks in during our 40s and 50s and beyond that makes it really difficult to lose weight. So let's dive in a little bit. Sue, can you allow me to screen share or pull up my slides? If you can. Let's see.
So you should be able to, Dr. Ochalski. Allow.
Well,
it's not allowing you to?
Yeah, that's okay.
No, it's not. I can, how about if I pull it up? I also have it. So why didn't you just talk for another minute or two and I will pull your PowerPoint slide up and we can look at it from my screen.
Okay. Obesity is one of the most prevalent chronic diseases, and about 70% of peri and postmenopausal women meet criteria for being overweight or obese. And it's the reason we care about it is not just because it's uncomfortable, but it's one of the leading causes of mortality and morbidity. We see increases in cardiovascular disease, diabetes, and cancers associated with obesity. And data shows that the average menopausal women will gain about a pound a year during the menopause transition. But it's not unusual that this can that can be exceeded. So 10 or more pounds during that transition. And some of it is associated with hormonal status, but there's also the changing effects that we see with increasing age and decreasing energy expenditure. And so if you'll go to that next slide, one of the most striking things that happens as we start to decrease our estrogen production is that we change where we gain our weight. So premenopausal, we deposit our extra weight in our gluteal and femoral regions. So more of a gynecoid distribution. And this type of fat distribution is linked to more positive cardiometabolic effects and decreases in insulin resistance. Then when we go through menopause and we make less estrogen, our male hormones, androgens, start to increase, and that favors what's called a more android distribution of fat. And we get the tire around our waist. So we accumulate our fat in our abdominal area and around our organs. And not only is this more uncomfortable, but it's more metabolically unfavorable. And with this type of fat deposition, we see increases in cardiovascular disease and metabolic diseases. And it's also associated with decreases in physical activity and quality of life. So I just have one more slide, Sue. if you'll advance it. And I think one of the most important messages, well, there's a lot of important messages that I'd like to convey tonight, but among them are that it's not just looks. Obesity is associated with cardiovascular disease, sleep apnea, metabolic syndrome, gallbladder disease, musculoskeletal disorders, and an increased risk of several different types of cancer. So tonight I want to talk with our WellSpan expert about what things we need to be aware of and what things we can do to both prevent and treat overweight and obesity. So with that in mind, Jen, what lifestyle changes can the average midlife woman incorporate to prevent and start to combat obesity?
So my response would be increasing activity as much as possible and decreasing your caloric intake, or also decreasing your carbohydrates, because we become very carb sensitive, especially in our 40s to 50s, and how we metabolize sugar and carbohydrates. So also abstaining, developing the healthier eating habits earlier, as far as abstaining from, the restaurant foods, the preservatives, the fast foods, the sugary beverages, alcohol, soda, juices. They're all kind of like the lifestyle changes that we kind of encourage patients to kind of get on board with, as well as even if it's a simple walking program for 15 to 20 minutes a day. Okay.
That sounds boring, not going out or anything, but I think part of that message is it's just the little things, those little changes, like maybe staying at home, cooking what we know is a healthy meal rather than, resorting to the easy, go out to the restaurant and order what looks good.
So it's not about, we want to promote socialization too with weight management. When you think about obesity medicine, as far as we don't want you feeling socially isolated. So it's just making, and it's not about being perfect. It's making the small steps. I mean, I have some patients who are in the habit of eating out twice a day, or stopping at Starbucks or Dunkin' Donuts for the large iced coffees or the frappuccinos. So making those small changes over time helps to prevent some of that excessive weight gain.
Yeah. I could tell you that personally, when I started to add up some of the calories from things like that Starbucks stop or that quick snack, when you're hungry after work and you just want to grab something quick, but those things really add up, don't they?
Mm-hmm. And even things that you don't think of, like certain condiments, like salad dressings. We're a culture of dipping sauces, like the barbecue sauces, the honey mustards, the ranch dressings. I mean, a lot of patients don't realize how much they're adding to their food as well that they could cut out.
That's a good point. You mentioned exercise. And so if there are listeners at home who don't have much exercise in their life, like what would be a goal to start out with? I think you mentioned 20 minutes.
So the Obesity Medicine Association, their recommendation is 30 minutes a day or 3.5 hours weekly of something purposeful where you are getting your heart rate up, you're breaking a sweat, and any little bit counts as far as exercise activity, raking leaves, mowing your lawn, vacuuming, light housework. I have a lot of patients that are limited by, chronic pain, joint issues as far as knees, hips, chronic back pain, fibromyalgia. So we know also that exercise is really only 5 to 10% of weight loss. It's more important once you've lost some weight to help prevent weight regain. But for women, you want to encourage that little bit of cardiovascular and weight resistance to help with decreasing inflammation in our body and just kind of increasing metabolism a little bit more.
I like that you said that, because I think that some patients have the feeling that you can just exercise more in order to keep up with, maybe an overabundance of calorie and food intake, but that's often not
The case.
beneficial, right?
Right.
Yeah.
And some patients just are not able to do the aerobic. So we encourage the, low impact, like water aerobics or just simple walking or what you can tolerate. Even, we've told patients to stand on one foot to brush their teeth or to just stand during every commercial while they're watching TV in the evening and maybe do like little 5-pound free weights during the whole commercial series. It's just any little bit counts.
Yeah, I like that. I've been trying to park as far as I can at work.
So I've told patients, park further away, even though we're always in a rush and trying to get in and get out of a store and grocery shop, still try to park away a little bit so you have that extra walk, or if you're at work, take the stairs versus the elevator. Even, some of us that are working at home virtually, take a walk at lunch, do flights of stairs periodically, anything to promote some calorie burn.
Yeah, I think that's particularly relevant with so many people working from home. I know I can sit at my desk for 8 hours straight, just communicating with the screen with virtual consults, and it's so easy to really not get up much at all. So,
right.
Okay, so for patients who are wanting to initiate weight loss, are there any specific strategies that you found to be particularly beneficial? That's a loaded question, I know, but.
So it's very patient, specific and individualized. So I try really to encourage the calorie tracking, because we know that calories are energy molecules we take in. So by reducing that energy that we consume as far as in food and calories, beverages, your body starts to use your weight as fuel, and that's what puts you into the deficit. So I try to give patients a calorie intake goal that's doable, and we promote that all foods are fair game, and to go into a weight management program thinking that you're not on a diet, because diets are usually for the short term. And like I said, promote deprivation, are usually socially isolating. We want to promote healthy eating for the long term that's doable, that's, short, realistic goals for patients.
Okay. What are your feelings about formal diet strategies? Like there's a lot of programs that use shakes, or Weight Watchers is another popular program. I'm putting you on the spot here.
Yeah. So fad dieting, we try, a lot of patients, once they come to medical weight management, they've tried Weight Watchers several times. They've done Nutrisystem, OptiFast, MetaFast. Again, those programs, they're doable, but usually for the short term. They're going to promote weight loss when you stick to their packaged meals and their program. But as soon as you start consuming more energy, as in calories, you're going to see that weight gain start to happen again. So by going into it thinking of realistic eating, that all foods are fair game and that all foods fit into your lifestyle and day, it's a little bit more doable for patients. They don't feel as restricted.
Okay.
So fad dieting, everyone's done it. I've done MetaFast, I've done, et cetera. They're usually, they're expensive, where we're promoting whole foods, fruits, vegetables, whole grains, lean protein, where you're eating and consuming and meal prepping and kind of cooking your own whole foods.
Okay.
Versus packaged meal plans or supplements.
Got it. So the listeners don't know this, but before we went live, Jen and I had a great conversation / heated debate about intermittent fasting, which I love, but Jen voiced some valid concerns about it. So tell us and listeners at home, what would be intermittent fasting is a pretty popular strategy that a lot of women, particularly midlife women, are dabbling with.
Mhm.
What have you run into that makes you pause before recommending that?
So that's a question that a lot of patients have, like at our initial consult. What do I think of intermittent fasting? So I tell patients, you choose your block of hours to eat, either a 10-hour, 8-hour, or 12-hour period, but they still need to stay within a calorie goal that I give them. For some patients, there's components of true binge eating or brain hunger, gut hunger. So if you go long hours, like 5, 6, 7 hours sometimes without eating, it sets us up to then being ravenously hungry. And I have some patients who then binge or larger portions faster without even realizing it. And it takes the brain about 11 to 14 minutes to even catch up with the gut. So if we consume a large portion within 5 or 6 minutes, then patients also tend to go back and have seconds before they've even felt the sensation of fullness. Or they do snacking while cooking, or they come in from work and it's boom, they're reaching for anything, or they binge. So that's my only hesitancy. I would pick a block of time. So I tell patients sometimes, if you want to start eating at 8 and end at 5, then there's your block of time, or 8 to 8 or 7 to 5, something that's doable where they still feel that they can eat. I would never encourage patients to do, food restriction for 1 to 2 days. I don't think that's healthy. It's not really doable.
Okay.
For long term, as far as like skipping days at a time, which some patients come into that idea thinking they're going to go 2 or 3 days without eating, period.
And listeners at home, I didn't mention this, but if I always intend for these chats to be informal, and I love for as much audience participation as possible. So questions for Jen or myself, please send them in. You can just type them in the chat feature, and it would be secure. Only the 3 of us hosts will be able to see it. So you had mentioned something, Jen, that made me think, like, are there any other tips and tricks that might be somewhat easy to incorporate into our daily routine if we were interested in weight loss? Like, what triggered that question is, I never knew that there was that much of a delay between when you eat and when it registers in your brain that you have just eaten something. Are there strategies for slowing down when you eat, or like chewing a certain amount of time? Follow?
So we encourage you think about shrinking down portions. Most of the time when I see patients, I list a whole list of, when I review their intake, I always list portions for everybody as a challenge, because most individuals don't realize what a real portion should look like or what should that be. So we try to really encourage smaller plates, smaller bowls, smaller glass sizes. I encourage patients for, tips, cutting up their food into really small bites. Chewing thoroughly, like chew to 22 is what we tell patients before swallowing.
Oh, okay.
Putting down your fork and spoon between bites slows down the rate that you're going to eat. Even if you have a family, try to keep, if you have kids, we tell patients, keep your kids on task with eating, start doing kitchen cleanup in between to slow down the rate that you're consuming your meal. Meal planning, or even meal prepping, like on a Sunday for the week, where you can do individual different small meals that you can grab and go to take to work. There's all kinds of things.
Yeah, that's really helpful.
Okay, ladies, I do have a question for you. Can you talk about insulin resistance? What is it exactly? What causes it? How is it diagnosed? Is it reversible, preventable, etc.? What should we know?
That's a loaded question.
That's a big one.
That very comprehensive. Congratulations to whoever put that together.
So I can speak a little bit on insulin resistance. We do a lot of management of prediabetes and type 2 diabetes at medical weight management. So insulin resistance, a lot of times comes, it can be hereditary. It can be due to that mid-abdominal weight gain that we see in middle-aged women. As we gain weight or as we age and we have stress, cortisol levels rise, which also leads to that mid-abdominal weight. So that in itself can lead to that insulin resistance where your liver is not producing enough glucose to break down or enough insulin to break down your glucose and carbohydrates. So can it be reversible? Sure. I have a lot of patients that come to me with a mildly impaired A1C, which is that diagnostic test for prediabetes and diabetes, that they might come at a 5.8 or a 6.0, which is that pre-range, and we get it back down to normal with weight loss. Even a 5 to 10% of initial body weight loss, which could be 10 pounds or less over 12 weeks, is going to be beneficial with decreasing that insulin resistance and even the cardiovascular disease prevention as well. There's medications. We use a lot of metformin at weight management as far as helping even with a mildly impaired fasting glucose. Early onset of some of these medications really slow disease progression. And that's the new wave. And even from if you see endocrinology for prediabetes or type 2 diabetes, that is the push, is early onset of some of these medications that can be weight neutral, that can help with weight loss, as well as lowering that A1C and fasting glucose.
Yeah, I think that was well stated, Jen. And sometimes it's hard to know what came first, the chicken or the egg. Certainly being overweight then promotes, there's a sense of insulin resistance. Being insulin resistant doesn't do you any favors to help you lose weight.
Right. And I have a lot of patients that, only come in at the overweight in an overweight category, not even in an obese category, that still have the elevated fasting glucose and the higher A1C.
Yeah.
I mean, you get some of our, sometimes some of your thinner patients have the worst looking labs versus some of our overweight patients, but we are trying to reverse, those conditions and improve those conditions.
Yeah. And I hadn't mentioned this, but Jen sees patients as young as 14, and conditions like polycystic ovary syndrome there's a high association with insulin resistance. And so early intervention can be really life-changing for many of these young women.
So I just wanted to touch on metabolic syndrome as far as criteria and definition when you had that listed on the slide.
Yeah.
A lot of times patients come to me, like I said, even with a BMI of maybe 27 to 29, which is just in the overweight category, but they meet 3 out of the 5 criteria, which is diagnostic for metabolic syndrome. So when you think of, if you have that diagnosis or you see that, that's typically because you have either an impaired fasting glucose, elevated or treated hypertension, high triglycerides, which is the fat content in your blood, a low HDL, which is the good cholesterol, and then an elevated waist circumference. So for women, that elevated waist circumference is 35 or greater. And in men, 45 or greater. So that's kind of the criteria. And to meet metabolic syndrome criteria, you have to meet 3 out of that 5. And sometimes that's what then will get certain medications approved to help treat your comorbidities and your weight. When I talk about comorbidities, that's the hypertension, the diabetes, the sleep apnea, chronic pain, etc.
Real quick, what are your take about supplements for insulin resistance like myo-inositol or cinnamon?
So I have a lot of patients that do cinnamon. They also do apple cider vinegar.
Oh yes, that's a big one.
So We have a slide that rotates at weight management in the waiting area that talks about vitamins and supplements. So we really encourage the whole foods and the dark green, rich fruits and vegetables for that good antioxidant effect that also helps decrease inflammation. So, you know, if patients want to do, if you have a vitamin D deficiency, you're iron deficient, or you have a B12 deficiency, then yes, I prescribe those replacements. But as far as like ordering a lot of like combo multivites from a company, et cetera, we just kind of think that's kind of, there's not real benefit. Just like the apple cider vinegar, there's no real evidence-based studies out there that promote that. There's a lot of literature, you know, you Google the cider vinegar, you're going to find pros and cons. There's going to be studies, just like the intermittent fasting. I went on today just to research, and there's an overabundance of information on
there
topics.
And, you know, I have a medical background, and it's overwhelming for me to digest, no pun intended,
Right.
all that data. I mean, it's really overwhelming. And you could read that, you know, we need to eat lots of tomatoes. And then you read the next article and tomatoes are bad. They're inflammatory. So it's really tough to navigate this stuff. That's why I'm so excited that you're here.
I have to agree. We have another question, and this one is really interesting to me because this is something my husband is all about. It says, how do you feel about the Mediterranean diet? I have several autoimmune issues, including fibromyalgia. I am considering using this plan. I feel that I eat healthy, no soda, lots of fruits and vegetables. Good job. I do need to step up my daily exercise, but I walk a good bit at work. However, I can't seem to keep my weight from creeping up.
So I can touch on the Mediterranean diet. So the Mediterranean kind of way of eating is, so we typically recommend 5 combined servings of fruits and vegetables, where the Mediterranean plan is like 7 combined servings. And when I say combined, you're not having to eat 7 fruits and 7 vegetables. It's a combination. They really encourage, you know, decreasing the complex carbs or the simple carbs like your whites. They encourage the good antioxidants in the dark skinned, like your blueberries, your blackberries, plant-based eating, like your spinach, limiting red meat, because red meat causes inflammation. It's hard to digest. Red meat's been shown to, you know, this is in men, you know, colon cancers, pancreatic cancers, et cetera. And it causes a lot of inflammation. So when you think about women, you think about wanting to decrease that inflammation to reduce your risk of like your breast cancers, ovarian, and uterine cancer. It also encourages, you know, up to 3 glasses of red wine a week. But there again, you need to be aware of the calories and what a serving is when you think about some of those things that you're doing. I mean, Mediterranean eating, it's clean. I have no problems. I have a whole packet that we go over the Mediterranean diet, but it's still, if you're not losing weight, then my concern is it's too many calories based on your height and your stature.
Got it. I can see that.
Okay,
Because it's not a free for all. I just want to mention, like other programs off, you know, not to brand things, but like Weight Watchers, fruits and vegetables were considered free points. Where with us, you have to count that cup of watermelon that's 45 calories or that medium apple that's 60. So it's still very calorie driven, and being mindful of what a portion would be or how much salad you're consuming at one time and then what you're putting on top.
That's hugely helpful for me because I always thought, well, it's a vegetable, it's a fruit. This doesn't count. So I have another question for you. Going back to the fasting, people talk about going on a cleanse, which is like 24 or more hours, or detoxify. Can you speak to those 2 crazy things? Can you tell my opinion?
So honestly, that's kind of gimmicky, and I don't recommend cleansings. It's really about putting your body into a caloric deficit. I can't emphasize that enough. Calories are energy we consume. You've got to decrease at least by 500 calories a day or more to be losing an average of a half a pound to 2 pounds a week.
And what's the goal? I mean, I know it probably varies, but what is a healthy weight loss?
So I tell patients at the initial visit that the goal is a half a pound to 2 pounds a week is healthy rate of weight loss. Some patients, if they come in with a higher BMI, they're going to see more weight loss at that 4-week mark. And that's a lot of times because they've been consuming 4,000 and 5,000 calories a day to maintain that current body weight. And a lot of patients don't understand that, or they become frustrated when I can put that into the calculator, the BMI calculation or the weight calculation, and show them this is what you have to be consuming most likely. And it sometimes is, you know, if they're eating out, like I said, 2 times a day. But as far as cleanses, no.
Not a fan.
No. I mean, you can do if you know, clean eating, increasing hydration, water intake. And that's another thing I can touch on. Water is kind of a misnomer too. I mean, we tell patients, this is another tip, to maybe drink an 8-ounce glass or a bottle of water before you eat, because it gives you that sensation of fullness. But water doesn't promote weight loss. There's a lot of other good things that water does as far as lubricating our joints. It's good for muscles, skin. But as far as just driving weight loss, you do not have to be drinking, you know, half your body weight in ounces of water or 2 gallons a day, et cetera.
What is your recommendation for patients who are on a weight loss regimen? Is there a minimum amount that you want them to drink?
So, and it depends on medication management as well, which we'll touch on. But I try to tell patients to consume, if they have a 32-ounce water bottle, to try to consume 2 of those throughout the day or in a 24-hour cycle. And everything is pretty much water-based. So if you think about coffee without creamer, unsweet iced tea, Propel Gatorades, the Crystal Light, it's all water-based. So that does include your water intake for the day. It doesn't have to be 32 to 64 ounces of just free water, if that makes sense.
Yeah, that's good. That's good info.
That's good to know for me. I have another question for you, ladies.
Yeah.
This one, I started menopause in my early 30s, and that has put me at increased risk for osteoporosis. What are the best items to incorporate into my diet?
Well, I would definitely recommend adequate calcium and vitamin D, and weight-bearing exercises. But any additional things you would add, Jen?
And can you specify what is high in calcium and vitamin D? Like, just throw out some ideas.
Yeah.
So low-fat dairy, green leafy vegetables. We get most of our vitamin D is synthesized through the sun. The calcium with the D replacement, and getting those, if you're already getting the annual DEXA scans, to continue that, to monitor your bone density. And when you talk about weight bearing exercises, that's something where you're jarring your joints a little bit. So like some power walking, or maybe even a slow jog for 30 seconds and then power walking in between.
Yeah, that's, and I think that those strategies are good for every menopausal patient and perimenopausal patient, because remember, our most rapid time that we will lose our bone strength is in that first year after we get our last period. So incorporating these healthy diets that have high calcium, high vitamin D, being outside, getting, our daily dose of sunshine it might sound boring because it's, there's nothing sexy about these things, but it's really, I think, tried and true. Okay, so Jen, you mentioned that there are some medications that can be helpful for weight loss. And I know these are going to vary, the indications, the benefits vary, but
Right. So there's
a little bit of more.
So like we talked about earlier, there's no one size fits all for patients. It's very individualistic, and it's a lot of times based on past medical history. So there are indications at times for anti-obesity medications, and then at times patients are not candidates because of certain comorbidities like AFib or heart arrhythmias or seizure disorder, et cetera. So we treat obesity as a chronic disease. Like we said, it's chronic, it's relapsing. Just like you would treat hypertension or diabetes with a blood pressure agent, we do the same thing with obesity. A lot of times patients do not take medications. We put them on our plan. And we always encourage that if we are starting medications, that there's no magic pill or we'd all be on it. So the medications used with the combined lifestyle changes, the reduced calorie program, the increasing your activity over time is what drives your weight loss. So medications that we use a lot of times are appetite suppressants. I talked about using a lot of metformin, which also helps with carb craving syndrome, or in my young girls with the PCOS, they find that, it does help with their appetite. I use a lot of low dose extended release of metformin, so it's less GI side effects if anyone out there utilizes metformin or has taken it. There's about a handful of medications that we do use. You want me to get into specifics?
Well, so I think the take home message would be that there are prescription therapies that can be used in addition to implementing diet strategies.
Correct. It's always used in combination with the dietary plan. And a lot of times the other factor is, we're fighting with, insurance authorizations, coverage. So not what one patient might be taking or get covered, I might not be able to use for someone else. Or same thing, I might have a 55-year-old female that has a history of AFib, so I can't be treating her with a central nervous system stimulant to suppress her appetite, where as someone who doesn't have the atrial fibrillation could take some appetite suppressant.
May I interject? Oh, I'm sorry, Dr. Howski. I just wanted to bring up the fact that you go into a health food store, quote unquote, and there are these supplements to take to suppress your appetite and so on, and to help your metabolism increase. And just as you're saying now that you are very careful about what you prescribe pertaining to the individual, I want people to also be cognizant of, just because you can purchase things over the counter, they're not necessarily safe.
Right. A lot of those appetite suppressants that are over the counter are very caffeine driven, or they're caffeine compound.
Heavy.
It's caffeine basically, where I'm giving you a prescribed medication that is increasing metabolism by releasing some of our brain chemicals, like serotonin and dopamine, that helps increase your metabolism while also suppressing your appetite.
And if a patient is prescribed a medication like this, what's the average amount of time that she would remain on it?
So typically for the central nervous system stimulants, specifically speaking to like phentermine or Vyvanse for binge eating, we're going to look at a 12-week time period. And if a patient isn't losing 5 to 10% of their initial body weight over those 12 weeks, then I'm going to stop the medication because it's not working. It's not helping. And you don't want to be taking these medications if you're not having help. However, newer studies show that long-term, that some of these medications long-term are safe, they're effective. They also help to prevent weight regain. So I have some patients who do take them long-term. They take holidays, meaning periods of time where they stop the medication and restart, or they might only take it on the weekends because they're out of their schedule and they're at home and they're snacking more and they feel like they're hungrier more, or they take it every other day.
Hey, we have another question.
Oh,
How
great.
much cardio versus strength training like activities would you recommend for those experiencing menopause?
All you, Jen.
So, you know, if you can tolerate, if you're capable of doing the 20 to 30 minutes a day of something aerobic where you're sweating, you're getting your heart rate up, you know, or even do, 30 minutes of cardio and then 30 minutes of some weight resistance. If you're going to like Planet Fitness or a gym where there's the circuits and you can incorporate the cardio with the weight resistance with different repetitions, then that's what I encourage. But it's what you can tolerate. It's what you can do.
Jen, at the end of our presentation, we will put up a slide so that patients know how to access your expertise if they are interested in setting up a consultation. But can you tell us what patients would benefit from having a visit with you and what their experience would be if they did have a consult with weight management?
So first of all, typically you do not need a referral to medical weight management. It's considered almost like an outreach of primary care. So it's going to be, based on a copay, what you would most likely pay at your primary care office. We see patients with a BMI of 27 or greater, or if you have tried multiple attempts at other dieting programs, like the MetaFast, the Weight Watchers numerous times, and you're struggling, then we really encourage, a lot of times primary care will refer or recommend, or it's even self-referrals or friends of friends that know that, that we exist. You can access, we're on, WellSpan.org under medical weight management in Chambersburg. That's our location. However, we have expanded services now that we're WellSpan to the West region. We offer the video visits in person. So if you're sitting in York or Ephrata or Lancaster or Manchester, you're able to access a provider at medical weight management via video conferencing.
That is
your follow-ups. We've even collaborated with the primary care offices that you do your weight checks at your primary care office versus having to drive to Chambersburg for a quick in and out weight check. Because a lot of times the weight checks, if you are placed on medication, that's what really drives your prescription, because we have to be monitoring your weight and recording those changes in body fat percentage, the percentage of weight loss, your BMI change, et cetera.
That's awesome.
You have those preconditions of the pre-diabetes, the diabetes. A lot of primary care offices kind of defer to us for that early initiation of the metformin, or if you've heard of the GLP-1 medications that you see on TV, like the Ozempic, the Trulicity, which are the weekly injectables. So we do a lot of that kind of management. So if you have the pre-diabetes or some of these pre-existing conditions, you can self-refer, or you can have your primary care refer to us.
A lot of patients that I would bring up a conversation about weight management, they automatically assume that it's going to mean surgery.
Right.
And in your experience, do you feel like that's the case, that the majority of your patients seeking care end up having surgery?
So it's 50-50 what they think when they're referred to medical weight management. So that's kind of like for your primary care to start that conversation, because if you truly want to go the surgery route, then they need to be referring into the bariatric program. There's a difference. So I do have patients that start at weight management, and I've laid out this big comprehensive plan, and they thought they were coming to talk to me about weight loss surgery. So I do bring that up at every initial consult by the end of the visit, because I've had some patients upset and in tears because they thought that's why they were coming to see me, was to start the bariatric program. So it's two different programs. There's medical weight management, and then there's the bariatric surgical line. I do have patients that come to medical weight management that are absolutely a no way on surgery, but then maybe they come to me for a year or two, they're struggling, they start to have weight regain because we know it's chronic, it's relapsing, and then they want referred into the Berry program, which I have no problem doing that.
Okay.
Bariatric surgery is one of our tools in our box to treat obesity. It's a legitimate treatment option. It should never be seen as a quick and easy fix because it's for the long term.
Okay. And for listeners at home who may have had bariatric surgery, can they utilize your resources and your expertise?
Absolutely. I have a lot of bariatric patients that have had surgery that saw me prior to surgery that I follow after, or I see a lot of patients that have had, you know, the sleeve gastrectomy or the gastric bypass with weight regain. We get them back on track, back with retraining your pouch or your sleeve. And I've actually had patients get below their post-surgical weight.
That's so awesome.
Jennifer, I have another question. Someone wanted clarification. You had mentioned about BMI 27 and above. Those are the people who come see you. But if you're below 27 with your BMI, can you still schedule a weight management consult? I mean, I'm even thinking about people who are too thin. But
so we do not do kind of, so that would be kind of going to a, maybe we don't really see malnutrition or low weight at weight management. It's going to be for your, you know, your overweight status, which is the 27 to 30, your class 1, which is 30 to 35, and class 2, and then your morbid obesity is 40 or greater. I do want to mention that we do see kids. I do see 14 and up with some early, you know, I'm finding I had a 15-year-old with the A1C, which is the diabetic lab result, that was like a 12.5.
Wow.
So I wanted to ask the person who sent that question in, can you be more specific? Like, why would you feel that you might need a visit if you're below 27? Because maybe there is a reason, just as Jennifer just explained.
So just to follow up, sometimes patients who have been a BMI of 24, 23 all their lives, and now they're at, you know, 27 or 28 or maybe 26, they might feel that that's the heaviest they've been through life. So they want to
be proactive
to prevent further weight regain. And usually I see that in my very petite individuals, shorter stature, that are starting to gain weight and they're uncomfortable and they get scared. So typically, you know, we say 27 or greater, or let's say you've had weight loss surgery and your BMI dropped to 25 or 26 and now it's creeping back up. So that would be another reason that we would see you.
So it doesn't have to be 27 or higher.
It does not.
Okay, thank you.
I agree, Jen, that I see a lot of patients who may not have that. They might be below a BMI of 27, but they don't feel like they're at their optimum and they're really struggling to develop strategies for weight loss.
The only time BMI really comes into play is medication management. So typically for medications, as far as the stimulants, you're looking at individuals who have that BMI of 27 or greater with a treated comorbidity. But with that being said, so if I get them down to a BMI of 25 or 26, we can still utilize medication to help prevent weight regain, like I mentioned, like every other day or every 3 days, etc.
Okay, so here's another really good question. Do you work with clients who are medically induced menopause because of endometriosis? What do you recommend for those who yo-yo with weight?
So I'll say that I do in the midlife clinic at WellSpan, I see patients who are menopausal for a variety of reasons, and a very not infrequently, I have patients who are surgically menopausal because of endometriosis. And can you speak to patients who are yo-yoing with weight?
So yeah, we would see you, we would just, you know, treat you as a typical patient, I mean, regardless of a history of the surgically induced menopause or your endometriosis, we would recommend, the certain foods to decrease inflammation, decrease the simple carbs. Again, metformin at times for, if you have a component of the history of the PCOS, et cetera.
Yeah.
It's really about when you have that endometriosis, decreasing as much inflammation as you can, like through your clean eating.
Yep. I'm glad you said that.
It's the same thing with my girls that have, fertility issues. They'll come to me, they're struggling with fertility. Then we induce, a rapid weight loss, even if it's through bariatric weight loss surgery. You're going to shed that extra thickening or that uterine lining, and that's what makes you more fertile, and pregnancy can occur quicker.
Yeah. And not just fertility, but we see changes in blood pressure control, insulin resistance.
Oh, absolutely.
Pretty early on in that, as part of that short-term goal. I think that it's even with modest weight loss, there are incredible health benefits. So like something I like to say is small changes can have really big effects. And has there ever been a patient who you would deny because it's a hopeless case?
No, we never kick anyone really out of the program. It's usually due to other reasons administratively, as far as not showing up for visits, et cetera. Or then the recommendation would be, okay, if we didn't try medications, let's try medication, or, let's really consider weight loss surgery. If it's an option and, they meet criteria as far as BMI, age, all those things play a part as far as when you think about the surgical realm too.
Yeah.
Jennifer, I have someone who really liked you talking about the anti-inflammation goal. So she wants to know, what type of anti-inflammation diet and lifestyle would you recommend?
So really increasing the fruits, the vegetables. When you think about vegetables, like I mentioned before, dark green leafy vegetables, think about rich colored, like red peppers, yellow peppers, zucchini, squash in the summer, plums, anything with the dark skin, the blueberries, blackberries. Blueberries are #1 antioxidant disease fighting food, power food that you can eat. The fruits and vegetables are what offers that antioxidant effect, which helps decrease your your risk for cardiovascular disease, helps keep your triglycerides low.
Anti-cancer properties.
Yes.
Talked about in our last chat.
Mm-hmm.
So going back to what Jen had mentioned before that last question, there's no person sitting at home listening to this who might feel like they're not at their ideal weight, and they know they're going to feel better if they get to a healthier weight. There's no one out there that I think this is outside of your reach. And so I'm emphasizing the fact that this could be really life-changing. Tonight, listening to what you're hearing and accessing the care that is available can be the first step in really turning things around.
And weight is a very sensitive subject. So it's an open format. It's multifaceted. So when we talk about behavior modification, the lifestyle change, the increasing the activity, there's a lot of the psychosocial component that we, discuss. A lot of times it's not even talking about weight management at the visits. It might be telling me, I'm stressed at work. I know that I'm mindlessly eating again. I'm stress snacking. It's due to this. We do a lot of referral to behavioral health. I do a lot of referral to, other, ancillary specialty like GI for, your reflux issues, or hematology for iron deficiency or B12 deficiency. So there's, and we're drawing labs. Sometimes an individual hasn't had a baseline screening of cholesterol, fasting blood sugar. So we do a lot of, we monitor labs.
Yeah.
We do a lot of even, we find hypothyroidism. We could start low dose Synthroid. We do a lot of med management for sometimes depression, switching out medications for weight neutral medications versus something that might be weight adverse or cause weight gain.
So I hope that there's ladies at home that are as excited as I am, because this is really an amazing resource that we have literally at our fingertips.